Both. We have some people who do just fine. In fact, it's easier, and there are others who have more toxicity. So it all depends. Am I using the right thing? Oh, I have to go like this? All right.
Clip it on that mic.
Yeah, this is like crossing the...
Clip it on the mic.
Okay, this is like crossing the streams in Ghostbusters. So how's that? All right. It depends. And again, people get a second transplant if they have disease progression a long time after their first one. If they're within a short period of time, like within a year and a half, it may not be as much of a benefit to do a second one. But if somebody say 5 years, we've had people go 10 years and then they get a second one and then they do fairly well. So, but it really depends. Some people do have the same, some less, some more, so it all depends.
There is nearly a study. We actually have not yet the approval from our institutional review board because this question came up, I would say, in nearly every patient meeting I have ever been, because people who are affected by myeloma get told that they have problems with their bones, they should not move, and they should not do heavy lifting and stuff like that. And so for several years, I have tried to get funding for a trial to do that, because there is data for lymphoma patients after transplant that they benefit. They benefit a bit less than I expected, but the problem is that this training was usually, because, I mean, you have to motivate patients to do a training every, I don't know, twice or 3 times a week, and this is challenging, and they call it adherence. When you do a clinical trial and the patient says, I will do that, and does it for 2 months, and the trial is for a year, the data is not really valid. So I think the trials until now were rather short. So what we are going for is at least 6 months, because as you all know, it's very easy after Thanksgiving to gain the pounds. After that, to get rid of them is more challenging, and I think we need longer period of time of training. And I'm personally, as a doctor, as a person, convinced that it is helpful. As a scientist, I cannot prove it yet. But yes, we are trying to get a trial up and running.
Well, we encourage movement. I mean, a simplistic view is moving around improves bone health. And we, in the past, actually had some funding to do a training program for our patients that physiotherapists came. And the details of the evaluation were not particularly deep, but people loved it. We now have excuse me, our hospital is affiliated with a rehab hospital, and we now have a formal program that patients are seen by a physiatrist and a variety of other professionals to help integrate their energy level and have someone look at what weight is safe to do for different degrees of bone injury, because people are very afraid if they have bone damage to do what they would normally do at the gym. So patients can opt to do this. I don't think it's being studied formally, but it makes sense. It's good if we move. It's good for everything. But there needs to be some guidance on what's safe if they're pre-existing compression fractures and such. But I think it's a really important area.
And we've done an analysis like retrospectively and asked in Heidelberg, where I'm from, 600 patients. And it's intriguing that myeloma patients love to do the things they are not supposed to do. I mean, our orthopedist says no impact, no kind of extreme movements. My patients rode skiing, golfing, tennis, so everything you're not supposed to do. But on the other hand, those patients did not fracture their bones during their exercise, interestingly enough. That's not like I don't tell you, do whatever you like. But we are looking into that, and I think it's great that other centers do the same, and then we can collect the data and
I mean, I'd be interested in other people's view. I mean, there is some information that exercise increases your lymphocyte count, and maybe now that we're so interested in immune effects on outcomes, I think that that would be a very intriguing aspect of this to look at.
it's
in
part
addition,
of our trial too. Yeah.
oh, very
Yeah.
good.
Yeah.
And in terms of sense of well-being and feeling like someone's getting a bit of their life back.
They say that sitting's the new smoking. And we do have a trial where patients are registered, and half of them are basically said, exercise and be active. And then the other half actually get a formal training program with exercise physical therapist and subsequent quality of life studies to find out at the end of the day whether exercise is a platitude that makes me feel better or whether it actually will provide impact for patients. I don't know.
Just, we did a study, retrospective, in our patients who are getting transplants from other people, so it's a totally different than an autologous setting. And we did show, and we presented an abstract form, we're trying to write up the manuscript, the patients who come in fit, in other words, have a good heart rate recovery, good oxygen levels, able to do sit to stands, and some of you know this tortuous thing that our physical therapists make you do, and a variety of different milestones which are quantitative. Those patients did better. So now what we have to do is prove if you intervene and make the people who have lousy tests improve, will that improve outcome? And so we're also trying to figure out how to study that. It makes sense, as everybody has said, but we need to prove it.
I suspect cytogenetics were sent, fish cytogenetics were sent. I think there is debate on what to do with the information aside from statistically get a feel for whose myeloma might behave more aggressively and whose might not. I mean, we haven't refined risk-adapted treatment, and centers do different things. We do something differently, and we are auditing and publishing our results of that, because I think if you decide what you're going to do, you have to see if it worked or not, even though this is not a prospective trial. We use our database to audit our results. But if you've already gone 3 years, that's a good sign. It's probably not going to change what is done now. There is a way, if most people have a bone marrow aspirate that's saved in the lab, and that can be used to do fish cytogenetics if you can find that sample. But I'm not sure it's going to affect what happens, because you have moved out of that 2 years where we worry the most about early relapse. So.
What's that?
I'll take it. I think it's common at these where a distinction is not made between genetics and inheritance. So the genetics we're talking about are acquired genetic abnormalities in the myeloma cells. The rest of the body cells are generally normal. So although there is a small subset of patients where there is some predisposition, myeloma is not an inherited disease. And we talk about the genetics of the plasma cells. That doesn't mean inheritance. And at our organization, we never screen siblings. We never screen children because we don't see it as an inherited problem.
Completely agree. And we do see, as Dr. Gertz points out, rare instances where there's a disease that runs in a family or heme disorders. So we're actually collaborating with somebody at the University of Chicago where we will ask to have blood samples sent on all the affected and unaffected members of a family who have this disorder. So for example, those of you who are hockey fans, Roger Nielsen, who died, he actually died of melanoma after having myeloma. His sister had it, so you would wonder if there might be a connection, but that's very rare. And then a large one for Hodgkin lymphoma is Mickey Mantle. Mickey Mantle's father had Hodgkin lymphoma. I believe his grandfather did, his uncle did. He drank supposedly because he figured he was going to get it, but he got liver cancer. But and then his kids had it. So you knew there was something there. That was Hodgkin lymphoma. So there's probably some genetic tendency there, but those are incredibly rare families most of the time. This is not, as to reiterate, not inherited.
This has come up as patients who've had transplants live longer and have longer remissions. And there's a recent publication, some of you may know, from France that looked at a third transplant through sort of a registry process. And there are two ways you can have a third transplant. One is if tandems or doubles are done at the front, and then there's a long remission, you can do a third. And then there's the situation where someone has one transplant, goes a long time, has a second transplant, goes a long time, and the question often comes up, should I have a third one if it worked well? I think these, and there is data to suggest that if you have a long interval in either of those situations, you might get a year and a half, a year, with the third, and that has to be compared with the non-transplant treatments. So I think technically with plerixafor, you can get stem cells almost out of a rock. So you can collect, we've recently done this, and we've had 2 individuals representing each of those cases come through our program recently. And the individual who, we were able to collect stem cells even after 2 transplants with plerixafor. But the question comes up, is it the right treatment? Technically it can be done, but is it the right treatment with all the competing treatments out there? So I think that's the harder question. I think in our own population, it will pertain to a very small proportion of people. But it can be done in terms of procuring the stem cells that you need to even do it. And once you're getting out to the third treatment, you know, what is your target PFS? You know, you get your most mileage with treatment number 1. I would argue you get your second longest period of control with disease number 2, with treatment number 2. What are you going to get with treatment number 3? And what is the transplant going to do compared to that?
I've done it in the past very rarely with success because we were the biggest transplant center in Europe, and we had some patients where we, for the third time, if we still had stem cells left, because we decided not to collect them again. If we had 3 in the freezer and we only used 1, then in relapse the second, and we had still 1, and we said, why keep it, right? It's the patients. So we gave it, but the argument was, if you have high-dose melphalan once, high-dose melphalan twice, the cells that come after that, they have survived 2 times of high-dose melphalan. So our theory was to change it to another drug, which is called bendamustine, which I brought not really with me from Germany, but can be used in myeloma. The results were not great. What we sometimes do, give stem cells back to, if the treatment we gave over the years really wore out the bone marrow, that we kind of reinfuse those cells to make the bone marrow strong enough to give another treatment. But with this bendamustine or with the change, it was not a huge success.
I think it's fair to say that the drugs reach the American patients faster than the other drugs, than the other countries, if only because it's the largest market in the world. It's a high priority to get them out to the U.S. I think Canada's sort of, and then my sort of perception is Europe's second, because that's the second biggest market, and we sort of come in around Europe or third. because we're a smaller market. But once it's covered, then it's universal without insurance distinctions in access.
We could spend an hour on the economics of how pharmacy pricing, pharmacy availability, et cetera. We are very fortunate here in the U.S. to have access. And it can be good and bad because sometimes things get used a little bit crazily. But it does mean, but it is great for patients to have access to those drugs. It's just figuring out, because we have so many of them, how to use them properly. Did I get to that slide? Yeah, I did. We've transplanted somebody who's 83, and he did fine. So it's fitness, not age, that matters. So we did have somebody who was even older who had a rough time with the stem cell collection, and she said, I don't want to do this. I said, okay, fine. So she's continuing on therapy. So it really is patient dependent once you get beyond a certain age. In Europe, there was a hard 65, which was, I think, probably too rigid, and now they're starting to loosen that up. So I think that it really depends on the patient. I think if patients decide not to get a transplant up front, they should have their stem cells stored. Now, you could argue if you have somebody who is older, like in their early 70s, and has their stem cells stored, and they may not need to use them until they're a lot older. So this whole issue of should you use them up front, get it over with, and then save for later, these are all sort of arguments that you could go back and forth.
I'd just like to make a couple of points. We have a soft cutoff at age 71, but in a very fit individual will occasionally go higher. I've been able to practice in both the U.S. and Canada as a transplanter, and I think the concern with older people, and you sort of alluded to this, is in someone who's fit, the mortality is not any higher, but the time to recover stamina and energy can be quite prolonged in someone who's older, I assume, just because things don't heal as quickly. So I think that time to really feel good, which eventually comes, you know, some of the people over 75 that I've personally done, it's just taken 9-10 months to that. And there was a time that we pushed stem cell transplant as much as possible in older individuals because we didn't have anything else. And now we have other treatments. I'm just going to reveal my biases. I came at this as a transplanter, and now I'm a myeloma doc that does some autografts. But one thing I always see missing from these reports that compare early versus delayed transplant is you never find out how long the second transplant worked. And when I've pushed an individual who had a poster of this a few years ago, well, the survival's the same, but once you get over a transplant, you're not on much. What was the PFS with a delayed transplant with the same survival? And the answer was 8 months. Now, I think that who wants to do a transplant if you're not going to get years? And I think that's a thorn in my side because, yes, you can make the survival the same, but you get the most bang usually with your first treatment. And why would you save a transplant if you're not going to reliably get years? And I've looked for that information with delayed. And there is a surprising number of people in the clinical trials that don't make it to second transplant, either because their disease is too virulent or they're not healthy enough. And that's a very important number because the treatments are, like my analogy, different beads in a chain. And you want as many beads as possible to make that chain as long as possible. And if you miss the transplant bead, I think you've missed it and you've lost a hunk of time of disease control. So I think this is something that people who are trying to decide about an early or delayed transplant maybe don't get a feel for because of the particular bias of their caregiver, their physician. So I think, as people are trying to decide what the best treatment is with all of these choices, if we're going to keep transplants and be nice to get rid of them, but they do something very different from other treatments, I think you have to look at what you get with each of these, and I just don't see good data for a long years benefit with a delayed transplant. It's my own bias.
You are right. It's very hard to get it. It varies from trial to trial. When you ask, like the Myeloma trial, the Italian study showed, I think only about 40% of their patients actually got a second transplant on the chemo arm.
And I think the French study, it was 78% could get a second transplant. That's 20% who don't and have lost that bead in a young population. So I think that and the durability of the delayed transplant are figures that if you can't find them in publication, you need to know what your center's results are. I don't know if you can tell I feel fairly strongly about that.
I'll do something really quick. One thing that's really important is that people need to give feedback to their treating clinicians. If you're starting to develop nerve problems like tingling, numbness, pain, any of that, don't be quiet about it. You have to speak up. And if they're not listening to you, you need to start yelling. Because there have been patients who have not been, I think, well treated because their neuropathy was ignored. So that's really, really, really important, number one. Number two, yes, there are other therapies being developed, and we've switched. I can just tell you anecdotally, I saw a patient the other day. She's being treated. She came here because she wanted to have her transplant here. She had support here. She's being treated in another state. She was still on IV bortezomib. I was appalled that because now it's all subcutaneous. So there's a good example of a lot of times you really need to be knowledgeable, because sometimes if you're seeing a physician who doesn't do this routinely, it's really important to get feedback or to get a second opinion from another center where they do a lot of myeloma.
I'm going to reveal another bias, and this is very, very Canadian, but in Canada we've abandoned largely twice-weekly bortezomib sub-Q. Sub-Q diminishes the risk of peripheral neuropathy slightly, but it does not get rid of it. And what gets rid of it is weekly sub-Q. And our Canadian, and it's not just our center, often we won't participate in a randomized trial if twice weekly is given, because we know even if it's not grade 3 or 4, grade 2 with pain is a miserable side effect. Yes, it usually goes away, but you have to stop treatment, then you're not getting treatment, and it may not go away completely. So we've given feedback to the manufacturer that product monograph that gives it that way is not the best for patients. There are phase 3 trials that have gone from twice weekly to once weekly because of toxicity and seen it diminish. But I think what was seen in the SWOG trial with 33% grade 3 or 4 peripheral neuropathy is really far out of the standard, and it doesn't need to be. I think there's enough data that giving it weekly retains efficacy, and you can give it longer, much, much longer than that's why I think the RVD Light from Nupur Raj's group is so important, because it shows in an elderly population with weekly, you get 3 years PFS with RVD Light. Very well tolerated. I think it was 2% peripheral neuropathy or less. So I think that physicians that don't do a lot of this, that is something that has not made it into the mantra of practicing physicians, but it's very pervasive in Canada for, I think, the right reasons.
There's a large meta-analysis being conducted. Actually, the statistician who's leading it is at the Mayo, Dr. Shi. And they're aggregating data sets from all over the world to do MRD analysis to see if it can serve as a surrogate for PFS and OS. there are patients who are MRD negative who have disease progression. There are those who are MRD positive who do not. I have some slides I can show. So it's not foolproof, and you have to incorporate other things such as cytogenetic risk and a variety of other things to be able to say for certain. The FDA, and I don't know if I have the slide, but they just approved MRD testing by next generation sequencing. It's called clone-seq by Adaptive. That now can be billed for. We don't know what it means though. We think it's good, but we don't have hard evidence to say, you're MRD negative, you don't need maintenance. You're MRD negative, you can stop X, Y, or Z at 2 years' time in maintenance. We don't know that yet.
Sorry to talk so much, but I have fairly, I'm probably the oldest person here and have the most polarized views. But I think right now, MRD negativity could be looked at as defining a super complete remission. It's good. If someone achieves that, it's good. But we don't have data yet that the converse is true, that if someone isn't MRD negative, that intervening and potentially giving them a lot more toxic treatment to make them MRD negative changes the course of the disease. And I think that there are trials that are looking at that. They'll be very important to see. But I think it defines a deep remission. It's essential to achieve that if you're going to cure the disease. But then there's the issue that you alluded to. A one-time MRD negativity isn't sufficient because you want it to stay that way. So how often should it be repeated? So do you intervene if it's positive? How long does it need to stay negative? But if it can be used as the endpoint of clinical trials, so we're not waiting 8 years for the results, that will be good for everything. So it's a good thing, but I think it just tells you you've got a deep response. And we know there are MRD positive patients, a subgroup of patients with myeloma, that the disease just sits there at a level for years and causes no harm. So you don't, as best we can tell, need to hammer those people in sear. So it's the disease heterogeneity too.
So again, MRD, minimal residual disease, is a measure of very, very deep response. What it means for us is that if you look at 1 million bone marrow cells, you cannot find the myeloma cells. It's less than 1 in 1 million. And it is prognostic, but I don't believe it can be used for any therapeutic decision making. So, Dr. McCarthy briefly said, well, I'm MRD negative. You can't find any myeloma in 1 million cells. I don't need maintenance. You can't say that.
I didn't say that.
Correct. So you can't use it to make a decision. And what I believe your question actually was, which wasn't answered, was you've gone from MRD negative to MRD positive, now what? And our answer to that also at Mayo would be, we wouldn't do anything because you can't use that as a therapeutic decision. And the final question is, I'm MRD positive, do I need more treatment to get to MRD negative? And you can't say that either. So we're collecting the data for MRD so we can eventually look and say, what are we supposed to do with it? But this question comes up a lot, and unlike fish genetics, which I believe needs to be done on every bone marrow every time it's done, out in the community, the doctor's saying, should I do MRD? And I'm like, why? You're not reporting it out. It's another couple $1,000. And how will you use it to make a decision if it doesn't tell you when to start therapy, when to stop therapy, or whether you should intensify therapy? So it's very important to look at, and yeah, if you're MRD negative, it's better. That's not the same as saying, I'm MRD positive. Now I need to do more stuff to get to MRD negativity.
As one corollary is, people do not routinely get bone marrow tests done. And so after transplant, we do them at 100 days. And then we've been doing them more at 1 year because it appears to be prognostic. But if you're having a marrow done just routinely, okay, then yeah, MRD positive, completely agree. Don't know what to do with it. If it's being done because the proteins are rising and you're MRD positive, well, you probably have other reasons to be treated. So therefore, it has to be taken into a context of what else is going on rather than just using that test alone to make a decision. You want that one?
Yeah, there isn't any evidence at all that diet affects the course of myeloma. Now, diet's really good to prevent heart disease and make you more resilient because it promotes atherosclerosis. But if we're going to start getting to an anti-cancer diet type of thing, that simply doesn't exist, or everybody would be on it. Yes, we talk about diets high in antioxidants and the like, and will antioxidants prevent genetic mutation? It's all speculative. To say that there's a diet that would, for example, promote the development of cancer, I think it's not true. Now, having said that, there is increasing evidence that obesity, which of course is a big deal in our country, is linked to a number of cancers, originally with breast. But now there's stuff coming out about obesity and myeloma. And so that has to do with kind of general healthful diet, but not specific beets, squash, green beans, or I eat rice, you know, and it's white, and I eat white bread. So there isn't very much data.
I would have just said no. But but there was a very cautionary tale, it's on my Twitter feed, of a fellow who was taking a green tea extract to feel healthy and went into liver failure. So you have to be really cautious about all of these things. Turmeric, green tea, vitamin C, blah, blah, blah. Nothing. And again, everybody thinks, oh, it won't do you any harm. These could be dangerous. Why? Because the FDA does not regulate supplements, and that's annoying. So garlic pills, there was a study recently showing that garlic pills often don't contain garlic. And you really have to be very careful about what you're taking.
And they're expensive.
That's enough.
No,
well, somebody's got to make money.
But I resent people making money off individuals who are trying to do whatever they can to stay healthy. That's another bee in my bonnet.
Yeah. Yeah, just to paraphrase P.T. Barnum, there's a sucker born every minute, and you have to be incredibly careful about this because we do not have good regulation on this, which is very unfortunate.
There's a difference between green tea and green tea extract tablets. Mm-hmm. My understanding and reading probably what you read is they're very different, and it's the green tea extract tablets that are clearly associated with liver failure as a toxicity. Green tea, and I'll turn this over to other people, the concern is it will interfere with the beneficial effect of bortezomib. And there are some other agents too, but I'll give that back to you.
Well, first of all, you could argue that if it's within 2 years, that's the gray zone is whether or not you should do a second transplant. But if you did, the idea being that you're now collecting cells that have been exposed to high-dose melphalan. So there's this back and forth. There's no right or wrong answer, but at least if you've got a lot saved, you potentially could have more trouble with counts recovering by using cells that have been beat up, so to speak. So a lot of times, every center does it differently. Sometimes they'll collect for enough to use over time. Sometimes they'll recollect, use those, keep the others in the freezer. There's more than one way to approach it. There's no right answer.
I need to understand, when there has to be something else than just protein levels alone. I don't think anyone would agree that on that alone, no matter what that level is, I've observed patients with 7,000 and 8,000 IgG levels and not treated them. So I want to be convinced you needed therapy. What else was going on? Nothing? A bone marrow that was just packed with disease? Oh, so you had over 60% plasma cells in the bone marrow. So from a statistical standpoint, this is statistics only. There would be an 80% chance you would have active myeloma symptoms within 2 years, so they elected to institute therapy. So, and so now having clarified that, and I will just tell you that I see patients who are 60 and I still don't treat them if their PET scan's negative. Same. So we're not all driven by the same philosophy. So some of those, because I worry about focal and they're not anemic, they look good, and I'll say, yeah, it's 60, but let's see in a couple months. But what was your question? I'm sorry, I kind of preempted. Oh, bisphosphonates. I think the standard of care for patients who've been defined as having multiple myeloma and are on therapy is to receive bisphosphonates with or without the presence of bone disease. I don't know if you do it differently.
Yeah, we at least will give them. And the one thing, just as a transplanter, if I find in our myeloma patients, we do DEXA scans, bone density scans as part of their workup. We find that myeloma patients have much less problems with osteoporosis and osteopenia than our lymphoma and leukemia patients who often come to us osteoporotic. And so I think the bisphosphonates truly make a benefit. There's no randomized for that for this sort of early, but I do think it makes sense to treat, provided you do all the mouth care things and all the things you need to do to mitigate the side effects of the bisphosphonates.
I'm going to take another view.
No, that's all right.
Our policy is, unless there's severe osteoporosis without lytic lesions, we reserve bisphosphonates for those with lytic lesions. And I must admit, and the data goes both ways, I think we saw in our center when the data first came out based on 21 months of IV bisphosphonates, there was less skeletal events. We started using it in everyone without any breaks. And you do see osteonecrosis of the jaw because supposedly, or there is data that when someone's in remission and not on steroids, they're not breaking down bone. So you end up with bones can't sculpt with time if you inhibit the ability to reabsorb bone, because our bone is dynamic. And if you're always building, the areas under high pressure over time can't adjust to that, and the bone just dies. So osteonecrosis of the jaw is miserable. So we're quite careful about if someone's in remission after transplant and off steroids, we'll restrict use to 2 years unless they have terrible bone disease, and then we'll go to every 3 months. But we try to give people a hiatus because this idea that if you hold bisphosphonates a certain amount of time, you can pull a tooth and there won't be a problem. I don't think there's any evidence for that. If there's osteonecrosis, the bone is dead. It doesn't come back during that hiatus. So we see a lot of that and have through the years. So we're quite judicious. They're great drugs, but I think you can overdo it. But again, if you look at all the different consensus criteria, that is only one of many.
Yeah, I absolutely agree with everything because it's a very individual decision. I usually use a lot of bisphosphonates for a restricted period of time, and then depending on, as you said, the bone disease and potential side effects. I have actually seen a patient where we just blindly gave it over 10 years in CR. She was a very young patient. She broke both bones because both legs actually without any trauma. We were nearly calling her family if she was beaten or something like that. We could not understand that. And then our radiologist actually came up with the idea that she had too much of bisphosphonate, and that made her, as you say, the bone was not able to recover properly. So be aware of that. But on the other hand, there's also this notion that the bisphosphonates stop the osteoclasts, these osteodegrading cells, from stimulating the myeloma cells. So it depends on the depth of the response, on the extent of bone disease, on the duration of the remission. So it's very individual. Unfortunately, again, as in myeloma, oftentimes it's not like one size fits all. You should discuss with your treating provider what is right for you.
I think the other thing that we've started seeing, again, we have a huge volume of patients, which just gives one a large landscape of seeing all different permutations, is, you know, the osteonecrosis occurs where there's a lot of stress and pressure, the jaw, the upper legs, but we're also seeing spontaneous fractures of the small bones of the feet, which are another area that need to be brown. So again, the benefit outweighs the risk, but I think where you just started and never look at it again is probably not. And we use bone density too, as well as the skeletal.